Today I want to talk about Clinical Research and Practice, the Journal of Team Hippocrates. It's a unique journal produced by the Wayne State University School of Medicine. It's open access, it's peer-reviewed, and it's scholarly research intended to teach medical students and clinicians alike. What they do is they take existing research and they apply it to a clinical situation. For example, I had the good fortune of working with a group about a case involving endocarditis, and we looked at a paper that evaluated the Transesophageal Echocardiogram as a tool in deciding if patients had endocarditis or not. Because this journal is open source, you are able to download the journal and the article free of charge, and you can look through our clinical research findings and come to your own conclusions. So I wanted to walk you through our journal article, but I wanted to do it in a more palatable format. Rather than just reading line by line, I wanted to give an accurate but succinct summary through a PowerPoint presentation. So Transesophageal Echocardiogram, accurate enough to make definitive clinical decisions related to endocarditis. And like any good idea in medicine, it began with a patient. For us, our patient was a 26-year-old female. She presented with subjective fever, malaise, vision changes, chills, night sweats, chest pain, shortness of breath, a new onset rash, and scratch marks over her legs, arms, back, and face. Her past medical history was significant for MRSA cellulitis, that's an infection of the skin, and IV drug use. Her social history is complicated by sharing needles with her fiancé, who is Hep C positive. Her physical exam reveals an isolated papule on her right palm, and during her hospital stay, she developed a new onset left knee pain with limited range of motion and effusion. At this point, our group is thinking of endocarditis. There's a tool to evaluate for endocarditis, and it's called the Duke criteria. Our patient met two of the minor Duke criteria: predisposition because of her IV drug use and immunologic phenomena. We also applied this case to the Jones criteria and found that our patient met three of the minor Jones criteria: fever, arthralgia, and leukocytosis. Our group then had to determine a pretest probability. How this works is we have a clinical case in front of us, this 26-year-old woman, and we have to determine her risk of having endocarditis. We decided that each individual member should assign a pretest probability, or an odds percentage, based on their own clinical experience. The individual odds percentages were then revealed to the group. We discussed why we picked that number. We then threw out our outliers, our lowest number and highest number were eliminated, and then we averaged the remaining percentages. Based on this clinical case, a consensus emerged. We assigned a pretest probability of 20% for endocarditis with an associated abscess in our patient. Now our group of doctors and student doctors is faced with the clinical question: what is the next step? What is the best test, treatment, or intervention for this patient? What about using a transesophageal echocardiogram, a test where a cardiologist uses a probe with an ultrasound? The probe is put into the mouth and down into the esophagus and takes a look at the heart. It looks at the valves for any lesions or any abscesses. How useful is this test, a TEE, in helping our patient obtain diagnostic certainty regarding a suspected endocarditis with associated abscess? Notice how we use the words helping our patient obtain diagnostic certainty. We're not doing this test for us as doctors. We're doing this for our patient to help her so that she knows exactly what's going on with her body, whether or not she has a lesion in her heart that needs further treatment. Next, our team looked through the existing medical literature for an article that would support our use of the transesophageal echocardiogram in our current clinical scenario. We wanted one diagnostic test, like the TEE, supported by a strong prospective study that would allow us to rule out endocarditis and associated abscess. We found this study in the New England Journal of Medicine. The study is called Improvement in the Diagnosis of Abscesses Associated with Endocarditis by Transesophageal Echocardiography. The study compared TEE versus direct visualization during surgery or autopsy. Looking at the heart at surgery or autopsy for abscess related to endocarditis is considered the gold standard. When the TEE was performed, 2 doctors reviewed the TEE. If they disagreed initially, they discussed and came to a consensus. This may not be the strongest protocol for a blinded study, but it is representative of real-life situations where you have reasonable doctors that may disagree, then they discuss the case with one another and come to a consensus. In this particular study, 118 patients were evaluated, and 44 of those patients were found to have endocarditis with abscess. TEE is found to have a sensitivity of 90.9% and a specificity of 94.6% for detecting endocarditis abscesses. The positive likelihood ratio is 16.8, and the negative likelihood ratio was calculated to be 0.1. Based on the patient's clinical scenario, there was a 20% chance of endocarditis with abscess. This is the pretest probability that our group came up with by averaging our individual pretest probabilities. After critically appraising the New England Journal of Medicine article, the TEE emerged as the best diagnostic test to guide our management. Our patient's TEE was negative. By using the Fagan nomogram, we were able to calculate a 2% chance of endocarditis with abscess in our patient. So we started out with this pretest probability of 20%. We then found that our TEE was negative, and so we got a likelihood ratio of 0.1. That was our negative likelihood ratio because the test was negative. We then came up with a post-test probability of 2%. We shared all of this clinical information with our patient, and we decided that no further testing would be needed. Ordering any other tests could have extended the hospital stay and/or increased costs without yielding any additional information regarding our patient's condition. With that, we decided that TEE is an excellent tool for diagnosing endocarditis and associated abscess in cases where clinical uncertainty exists. Thank you very much for watching this case.